Right, ladies and gentlemen, welcome to this New Year's first show of the Icrcpi, the webinar for the month of January 2021. And basically, today we have got some fantastic topics and some new speakers, some of whom we had never heard before. And we have got a variety of topics just in keeping with ideas of the concept of RCPI, because RCPI gives you a postgraduate qualification not only in medicine but also in obs and gynae. So basically, we have got three topics, and the three speakers are Dr. Abhilash Tiwari, Dr. Sudeep Basu, and Professor Rangaraj Seklur. And the chairperson for these three sessions are respectively Professor Sujoy Roy Chaudhary with Dr. Abhilash Tiwari, uh, Dr. Vinu Balakrishnan for Dr. Sudeep Basu, and Dr. Bijan Bhattacharya for Dr. Rangaraj Seklur. So without wasting much time, I think we can go ahead with the meeting right now if everybody else has joined. So I'll leave the stage open for the speakers. But before we start, there should be some opening remarks from Professor Jain, Professor D.G. Jain, and Dr. Sabyasachi Rai, the chairperson of the Indian chapter. So, Professor Jain, please.
Thank you, Dr. Mazumdar. And firstly, a very happy new year to everybody, and winter greetings to all the distinguished ladies and gentlemen of the medical fraternity gathered here on this digital platform. Firstly, my congratulations go to the Indian chapter of the RCPI, headed by our regional advisor, Dr. Sabyasachi Ray, and a very dynamic, supportive team of eminent senior fellows and members, that is Dr. Monojit Ketan Mukhopadhyay, Dr. Sujoy Mazumdar, Dr. Sagarika Mukherjee, Dr. Deepika Kedia, Dr. Ranadit Chatterjee, and many others, for organizing this monthly webinar regularly on behalf of the Royal College for the basic promotion of medical education and clinical skills in the Indian subcontinent. Today, I recall Swami Vivekananda's inspiring words, "Arise, awake, and do not stop until the goal is reached." For all medical students who have graduated from all the various medical colleges in India and in the subcontinent, and who wish to carve out a future in clinical medicine, the ultimate goal ought to be the MRCPI, the membership of the Royal College of Physicians Ireland, which is recognized around the world as an international benchmark of excellence in medicine, opening up new opportunities for career development. By successfully completing the MRCPI examination, you are joining a global network of respected physicians whose roots date back to the year 1654. It also sets you on the pathway to fellowship of the Royal College, which is again a career milestone and an international benchmark of professional excellence. Our fellows are experienced hospital consultants who have made substantial contributions to their specialties. Globally, there are over 11,000 fellows, members, licentiates, and trainees in more than 84 countries. Today, we are in the midst of a mind-boggling age of unending information, knowledge, and technological ferment. At the same time, we have this disturbing feeling that global pandemics like this COVID-19 are here to stay, with more viral mutants in the pipeline. Therefore, webinars like this one are the need of the hour for disseminating and sharing practical knowledge and wisdom amongst clinicians, so as to equip them to effectively face the day-to-day challenges in the world of Medicare. Today, on our academic platter, we have three interesting dishes. Firstly, an evidence-based approach to health examination, in which we will be learning the latest in comprehensive prevention and screening recommendation by Dr. Abhilash Tiwari, who is Medical Director of Sai Healthcare Hospital, Mumbai. As chairperson, we have Professor Sujoy Roy Chaudhary from the Department of Medicine, Vivekananda Institute of Medical Sciences, Kolkata. The second dish we will be guided through the diagnostic and therapeutic dilemmas in PCOS by Dr. Sudeep Basu, who is a consultant gynecologist and fertility specialist at Shrishti Infertility Clinic, Kolkata. Dr. Vinu Balakrishnan, senior obstetrician and gynecologist from the Kerala Institute of Medical Sciences, Trivandrum, Kerala, will be the chairperson for this session. Finally, we have Dr. Rangaraj Settler, Head of Anesthesiology and Critical Care at the AFMC, that is the Armed Forces Medical College, Pune, who will enlighten us about what the anesthesiologist expects from the physician as far as the pre-operative consult is concerned. As chairman for this session, we have Dr. Bijan Bhattacharya, Head of the Department of Nephrology at the Ruby General Hospital, Kolkata. Wishing you all a very fruitful and enriching update. I will now conclude with some more words of wisdom by Swami Vivekananda. He said, if you win, you can lead, but if you lose, you can guide. Thank you.
Thank you, Professor Jain, for such excellent words of introduction. And it is probably not out of place to remember that we are just 2 days away from the birth anniversary of Swami Vivekananda. This will be his 158th birth anniversary. So, such a lovely person who had given this aphorism that a man can approach God more by playing football than by reading the Gita. Something which was absolutely atypical for a religious-minded person of that age. But anyway, let us move on to next speaker, that is Dr. Sabyasachi Raya, the chairperson of the Indian chapter, to say a few words of introduction.
Good evening, everyone. And once again, from me and on behalf of the Indian chapter, Royal College of Physicians, very welcome to this webinar and very happy New Year. Truly speaking, we do need to have a happy New Year to 2021 after the awful 2020. And I would reiterate from what Professor Dinesh Jain said and say that I'm very proud to represent a college that is our College of Physicians of Ireland, which has just celebrated 365th year, one of the oldest medical institution in the world. We, the Indian chapter, officially inaugurated in 2005. Since then, we have been engaged in organizing MRCP examinations, as well as holding the seminars and CMAs throughout India alone and in association with other institutions in this country and also in the neighboring countries like Bangladesh. And unfortunately, with this lockdown, which followed this COVID-19 pandemic, has stopped our professional life and affected our life professionally and personally very severely. And then now it's gradually opening up. And that's why we decided to continue our academic activity through webinars. And we started a series of 6 webinars from September. This is the 5th one. And that's why we will continue to impart the knowledge and gain momentum in our academic learning in this process. And that's why we are here today with a variety of speakers. I wouldn't let you wait too long for them to speak. And therefore, I think we'd like to continue that with this today's webinar, we'll learn a lot, take home message, which will be useful for our usual practice. And over to Dr. Sujay Mojumdar for continuation of the webinar.
Thank you, Dr. Ray. So without wasting much words, let us invite the first set of speakers and chairpersons, Dr. Abhilash Tiwari, the speaker, and Professor Sujay Raichaudhuri, the chairperson, both of whom have already been introduced by Professor D.G. Jain. And I can only assure you it's going to be a very exciting talk. So without wasting much word, over to you, Professor Raichaudhuri.
Yes, good evening, everyone, and all the doctors and delegates who have joined this session of the Royal College of Physicians, Indian chapter. Initially, we are starting off with a very interesting talk by Dr. Abhilash Tiwari. He's a very esteemed speaker, and he'll be talking on a very relevant topic, which is very important in today's times. This topic is comprehensive prevention and screening procedures, evidence-based approach and health examination. So as you know, sometimes we physicians as clinicians, we are forced to see when you are investigating how much to go ahead with investigations, how much to do and what not to do. So he'll be presenting to us some important guidelines, which will have helped all of us while choosing and screening our patients and evaluating them for any possible metabolic or neoplastic diseases. Keeping that in mind, I'll now call over Dr. Abhilash Tiwari, who's a very esteemed speaker, who's from the director of Sai Medical Center, Mumbai, He's a member of the Royal College of Physicians of Ireland, and he's had a lot of qualifications, as you have seen. So without wasting much time, I'll invite Dr. Tiwari to talk on this important topic, which is comprehensive prevention and screening recommendations with evidence-based approach to health examination. Dr. Tiwari, please.
Yeah, good evening, senior colleagues, practitioners, friends, and students of all the ages. It's a matter of proud and privilege for me to address today the eminent clinicians and the speakers and the doctors across India and the globe, and especially for the Royal College of the Physicians of the Ireland. Friends, I have chosen this topic deliberately as you have seen the comprehensive prevention and the recommendation.
Can you, excuse me, Ravilas, can you share the screen and
Yes.
slide?
Yes. Yeah. Devashish, sir.
What happened?
Yeah.
Dr. Tiwari, you should be sharing your screen.
Yes.
Have you started doing that?
Yes. I have already asked Devashish, sir, to do that.
No, but you should be sharing your own screen. I mean,
Yeah,
not Devashish.
Yeah. I think, is it visible for all of us?
Yeah, it is.
Can you make it full
The next
screen?
slide. Yeah. Next slide.
Put it in the slideshow mode, then that will be easier. Devashish.
The next one. Yeah, the next. Without wasting much time, we'll proceed very fast because it's a very huge topic. Yeah, next slide. Yeah. So friends, let me start it. Whatever I'm going to talk is based upon the A-grade evidence and the B-grade evidence is provided from the United States Service Preventive Task Force. Let me make it very, very clear that these recommendations vary from country to country, the guidelines from guidelines and from various places. Whatever the evidences I've tried to filter with an A-grade evidence followed by the B-grade evidence. So there might be some differences. The purpose of this entire talk is that we as a clinician is more reactive than rather proactive in our approach. We see a patient who's already deceased. None of the patient comes to a clinic who says that don't want to fall sick. Can you prevent my cancer? Can you prevent my heart attack? Few days ago, we have seen one of the eminent cricket player suffered from a fatal myocardial infarction. He survived somehow. And then there was a talk of the talented. So my talk is all about all these things. So there are many tests which are there in the market, and you can see that every year a new test is introduced in the market to detect an unrecognized disease or the risk factors of the disease. Other condition needs to be fulfilled for the screening. But let me tell you one thing, that the benefit of screening must be always balanced against the potential harm, including the false positive results and the risk and cost of the follow-up procedures. Let me tell you that even when the tests have a high specificity, the majority of the positive results will be false positive if it is tested to screen a healthy population. So why do we need to screen a disease? I would simply give an example of the cancer. As we have seen that there is a growing evidence that cancer screening can lead to overdiagnosis and detection of slow-growing cancer that would never have caused any clinical symptom in the patient's lifetime. So the overdiagnosing a subject to the side effect of treatment with no benefits. So really small number of screen tests have been proved to be beneficial in the general population. So today what I'll be talking is the most commonly used tests that are not recommended by the United States Preventive Task Force. I'll be using as a preventive task force because they provide a little benefit or the lack of sufficient evidence to prove or disprove their value. Since only about 50% of these patients are seen at the primary care. So let me first start. What should be an effective requirement of an effective for the screening test? First and foremost, the disease being screened is an important cause of mortality and the morbidity in the society. Second, the screening can detect disease in the early pre-symptomatic phase. The screening test and the treatment of the patient with the early disease or the risk factor produces a better health outcome than does the treatment when they present with the symptoms. Screening test is acceptable to the patient and to the clinician. Safe, convenient, acceptable, false positive rate, and acceptable cost. As you've seen many times, the debates are there. No, it is not required. It is falsely positive. It is no need. For example, the coronary CT scan, a lot of debate. So the benefit of an early detection and treatment are sufficient to justify the potential and harm and the cost of the screening. So I often tell in my lectures to all my students that the prevention is not just better than cure. It should be cheaper than cure. I'm using the word cheaper than cure. Next slide, please. So what should be the screening one? This is a simple thing which I have seen: height, body weight. Next slide. Height. Yes, from the US preventive. This is the guidelines which I'm using it. Height, weight, the body mass index should be calculated periodically. Why the history and physical examination is important in every individual whom you are about to screen is, it helps us to delineate or select an individual who is at the high risk. Some patient may say that I have a strong family history of premature myocardial infarction. Some patients may have a premature chronic renal failure. Some patient may have a premature history of family history of breast cancer, BRCA1 mutation, BRCA2 mutations. So history and physical examination helps a clinician to delineate and discriminate and to bring to the point that these individuals require a special recommendation. So here also, in all the patient, you must do a blood pressure at least every 2 years. Friends, let me tell you, the gold standard for the detection of the blood pressure is the 24 hours ambulatory blood pressure monitoring, which has come up now. Next is the screening for alcohol misuse. So this is a very misnomer term. Who will accept that I misuse the alcohol? I don't understand. Everybody uses the alcohol. The patient comes to a clinic and says that I've read in the newspaper the doctor recommend 1 or 2 peg of alcohol. So this is a very delicate question. Nobody would accept that alcohol misuse. Rather, they're using the alcohol even in the medical fraternity. From the purpose here to screen alcohol misuse is you must always try to have a cage questionnaires, which will help us to understand much better the extent to which the person is dependent on alcohol or has been addicted. Next is a brief screening for depression. Friends, it is very sad to tell me that 30% among the fraternity of various populations, from chartered accountant, engineers, medical, 30% of the medical fraternity are depressed, and majority of the doctors are often having a drug abuse and they are even committing suicide. This is the high for the depression is very essential. And this is very important. There are simple questionnaires we'll see in the subsequent slide. That is a patient health questionnaires are there. It consisting of 9 to 10 points, friends. And if the patient exceeds 10 points, please understand the patient requires interventions and treatment recommendation. If it exceeds more than 20, the patient is in major depression and needs urgent psychiatric treatment. But apart from it, we usually screen the pregnant women and the postpartum states. Needless to talk about the total cholesterol. It is a comprehensive part in all cardiovascular assessment. Friends, here I have not covered the diabetes because the USPT firmly believes that diabetes, dyslipidemia, and the other age, gender, blood pressure, and the lipid profile is included in this parameters. Next is the colorectal cancer screening, which should be done from the age of 50 to 70 years. Now, there was a debate. Fecal occult blood test is no longer recommended. Rather, high sensitive fecal occult blood test has been recommended. You can go for CT colonoscopy. Some of the guidelines clearly recommend to have annual colonoscopy because it has got both therapeutic as well as the diagnostic utility. But the United States Preventive Task Force clearly mentions that none of the individual investigation to screen or availability of the resources. Mammogram should be done every 2 years for a woman between the age of 50 to 74 years. Let me tell you, friends, for the students who are appearing for the MRCP examination during my time, it was very clear that it should be done by the patient self-breast examination. This word is removed from the preventive task force. Either it should be done by the physician annually, or at least 2 years from the age of 50 to 74 years. You should subject your patient for the mammogram. Why? Because the self-breast examination done by the patient, if you educate the patient, they become hypochondriac, and majority time they land up that I find some unusual lump in my breast. So that's the reason they no longer recommend self-breast examination. Cervical cancer screening, papinocular test, which is done by the gynecologist, we often recommend every 3 years for the women from the age of 21 to 29 years. And for the women age 30 to 65, either pap test every 3 years or HPV test. That is a molecular test every 5 years. Friends, I would like to add some important point here. Is many a times when you do epithelial cell, many a time indeterminate results are there. Here, the preventive cervic task force recommend that using both HPV molecular tests along with the pap test increases the sensitivity. So it should be combined. And as far as the HIV is concerned, at least once in their lifetime. Chlamydia and gonorrhea, all sexually active women less than 24 years. Why it should be done? The cervical smear, the urethral smear, you can do by the nucleic acid amplification test to detect it. Why? You can prevent the ectopic pregnancy. As far as BMD is concerned, it is to be recommended in a woman's more than 50 years. than 65 years of age, recommended as a prevention of the osteoporosis. So let me be very clear. Next slide, please. Next slide. So the counseling is to be done on the part. Friend, let me tell you, may ask me about the certain guide, which is usually done by the psychologist, which I have not from the preventive service task force recommendation. But suppose if you come across a cognitive impairment, which cannot be reversed, like in vitamin B12 deficiency, by screening or diagnosing the test, you cannot have any therapeutic benefit in this individual, and it is very cumbersome. So there is no specific intervention or substantial enough impact on the progression that warrants the screening. Hence the reason I have not included it here. The cognitive impairment is a part of the comprehensive screening recommendation. The counseling is very important, friend. That is a time-consuming job, and we are overloaded. So you must educate your patient about the tobacco cessation, reduction of the risk and the harmful alcohol use, diet including grain fruits. These things we have covered in the cardiovascular chapter in subsequent lectures. And the regular physical activity, sexual behavior, unintended pregnancy, contraception, and the dental health. Next slide. About the vaccination program, we should have it, and 1 year apart in the age 65 years. One is PPS 23 and conjugated 13 vaccines. Friends, remember, take home message: if you have an individual who is a compromised HIV patient, organ transplant recipient, aspirin patient receiving immunosuppressive treatment, first you should go for the conjugated vaccination. 8 weeks apart, you're going to give them PPSC 23. Otherwise, in all the cases, you are first going to give PPSC 23, followed by the conjugated vaccine 1 year apart. 1 year apart, I'm using the word. They say that it adds the additional antigenic coverage and added benefit. Annual influenza vaccine is recommended now in US for all the patients. Even in our part of the country, many people are using it. Tetanus, diphtheria, booster dose has to be given every 10 years. Measles, mumps, rubella, MMR vaccine. Susceptible adults over 19 to 49 years has been recommended. Out of which the varicella, 2 doses to the susceptible individual born after 1980. And herpes zoster, please take home message. Herpes zoster should be recommended to all the patients who are over and above 50 years. And human papilloma virus vaccine should be given not only to the girls, but equally to the boys in their early reproductive age. If the boy has crossed the age of, say, 25 years, or the girl has crossed the age of 25 years, you need 3 doses of vaccination instead of 2. Let me tell you, there are certain guidelines which recommend that you can use this vaccination up till the age of 45, but the preventive service task force does not recommend beyond 26 years of age. But certain guidelines I've seen, they recommend that you can use it. Why? Because the carcinogenic strain 16 and 18 serotype of HPV, which is an oncogenic type, if we can prevent it. So that is one of the guidelines.
Microphone is getting muted.
Next slide. So the chemo preventions with the folic acid supplementation is the women who are planning, okay, people, as we all know, that we usually give folic acid just before to prevent the neural tube defects. Now that we are talking about the benefits and the harms of aspirin to prevent the cardiovascular disease and the colorectal cancer in middle age. Yes, to a certain extent, the use of the aspirin is one of the very important part, because it definitely reduces the colorectal cancer, but it increases the risk of GI bleed. Now, as far as the benefits of the aspirin, if you see from the age group of between 45 to 65 years, there is a moderate benefit. But if you talk from the age of 60 to 70 years or between, there is a very mild benefit. And so the benefit does not outweigh the risk. There is definite high amount of risk. As far as the diabetes is concerned, with dyslipidemia, aspirin is no longer recommended as a preventive therapy for the primary prevention. Definitely for secondary prevention we're using, but for the primary prevention, they are no longer recommended. The benefit is moderate in the early age group and very less in the age group above 55 years of age. So definitely we often calculate the atherosclerotic risk factors in a majority of the cases to calculate it. And the US usually considers that all patients should be given the high dose of statins, moderate to high intensity statins, if the score is above 7.5%. But let me tell you, the preventive service task force says that this 7.5% overestimates. There's no benefit out of it until it crosses the 10%. So this is one of the important take-home message which I want to give it to you. Next slide. Next slide. Ultrasound to detect for the asymptomatic abdominal aortic aneurysm. The size is more than 5.5.
Voice is very much cracking, Abhilash. Voice is very much cracking.
Definitely.
Can't hear you. Can't hear you.
Can't hear you.
In specific immigrant groups, especially the prisoners of war,
Can't hear you.
Please check your network, Abhilash. Please check your network. Not at all audible.
yeah, can you hear me?
No.
We cannot hear you properly, Abhilash. We cannot see you also.
Hello.
Yes.
Yeah.
Okay.
Yes, no. It's...
Carry
Can you
on.
see me?
You do one thing,
Yeah.
you just switch off your
Is
video,
it?
you just carry
Yeah.
on with your voice, I guess. That will be make it
Just a
easy.
minute. Just a minute. Sorry. Hello.
Yes.
Can
Yes.
you see me?
I can
Yeah.
see the screen.
Yeah. So yeah, is it okay?
Yeah, it's okay. Carry on.
Please carry on.
Yeah. So the hepatitis A vaccination, meningococcal vaccination in the certain high-risk categories, especially the military recruits, students in dormitories, and the asplenic individual. Varicella vaccination, we have just talked about it, and the breast cancer chemo prevention. Yes, by using certain molecule like tamoxifen and other molecule, whatever we are using it, they're no longer recommended as a preventive measure for the prevention of breast cancer for the reason that increases the likelihood of thromboembolic diseases, as well as the increased risk of the breast cancer as well, and endometrial cancer. So they are no longer been recommended, though it has been used to prevent the breast cancer, but it increases the risk of endometrial cancers and thromboembolic complications. Diabetes screening has already been included as a part of the comprehensive cardiovascular disease prevention. So they are not, we do not try to cover it as separately here. Next. So the interventions which are not recommended for the routine use in asymptomatic average risk. So this is which I don't want, that resting electrocardiogram or helical computed CT scan for asymptomatic coronary artery disease. Yes, there is a word of debate which I just want to clear here, friends. There are certain guidelines which I have received few days ago that they have found that the coronary calcium score is now much more reliable than the coronary artery stenosis which is detected on the coronary CT scan. But let me tell you, the latest guideline has still not incorporated the role, though they are found to be much benefited in detecting the asymptomatic coronary artery disease. So that is to be take home message for all of us. The ultrasound examination for asymptomatic coronary artery disease carotid artery stenosis, there's no longer been done. It is not recommended for the routine use. Cancer routine blood test for the anemia, routine urine test for the infection, cancer, or the chronic kidney disease. The blood test or the ultrasound examination for the ovarian cancer, the whole body CT scan is no longer recommended. Vitamin supplements has got no role at all. As I've said you clearly that the calcium and vitamin D is not recommended for the prevention of osteoporosis, herpes serology, and the blood test for the celiac disease. Next slide. So these are the very important, friends. This is a simple, I think this is very, very simple. It will take hardly 5 minutes if you're a busy practitioner. This is a patient health questionnaire to detect the subtle depression in an individual and the doctors. The simple questions I have said you, if it is more than 10, that whether you feel little interest or pleasure in doing the things, do you feel low down or depressed? Do you feel trouble falling asleep? Do you feel tired, lack of energy? Friends, a patient comes to your clinic with unexplained chronic fatigue. In absence of any organic disease, always think of depression, always think of, and especially in medical colleague, our fraternity people who comes to our clinic for the checkup, they often have a history of drug abuse, alcohol abuse. So do not be carried away if a person is a doctor or from a medical fraternity. Always screen this patient health questionnaires in them, and be careful about them. So this is something which you can go through it without wasting much time, because we have a less time here. Next slide. Yes. Now, thank you. Before this, I just deliberately tried to cover the slide. There are certain things which I just wanted to cover. You may ask me that, Avilash, we have not covered about the prostate PSA test, friends. So let me tell you that the Preventive Service Task Force concluded that the PSA-based screening program in men between the age of 55 to 69 years may prevent 1 or 2 deaths from prostate cancer and up to 3 cases of metastatic prostate cancer per 1,000 men screened over 13 years. But these benefits are offset by the harms of screening, included an estimated of 15% risk of false positive test necessitating a biopsy. So this is the reason that the majority of the guidelines do not recommend the PSA test in their routine examination. Apart from it, friends, the thyroid disease we do not do as a routine screening test, and the other part. And as far as the behavioral interventions, as we have seen, the tobacco cessation, healthy lifestyle, low saturated fat intake, all these things has to be seen very clearly. And again, I would like to reiterate the use of the pneumococcal vaccination. Again, I would say that the PPSV23 is, if you're giving it first, within a span of 1 year, you should use a conjugate vaccination, not before that. And in an immunosuppressed, immunocompromised individual, you're going to use the conjugated vaccine first with minimum gap of at least 8 weeks, then followed by a PPSV23 vaccine. So with this, all friends, I'm just trying to curtail. And the role of aspirin, again, I would like to tell you that the Preventive Service Task Force has concluded that among the men and women who have increased elevated risk of cardiovascular disease, that is 10 years risk of at least 10%, the benefit of aspirin outweighs the risk of moderate amount for an adult between 50 to 59 years by only a small amount in those between 60 to 69 years. Hence, as a result, it is recommended that decision regarding the aspirin use should be individualized based on the additional consideration of the risk and the patient values. As far as diabetes is concerned with dyslipidemia, it is not recommended as a primary prevention. So this is very important, and the role of, I've said you tamoxifen and raloxifene already, that it definitely reduces the incidence of invasive breast cancer by 50%, but at the cost of increased thromboembolic events and worsening of the menopausal symptom, as well as it increases the risk of endometrial cancer. About the post-menopausal hormonal therapy, only indication as per the Preventive Service Task Force, a woman with the early premature menopause with very troublesome menopausal symptoms is the only indication to start the post-menopausal hormonal therapy. No role of vitamin and minerals. So what are the future issues about the prevention? The preventive care recommendations often vary based on the patient's characteristics such as the age, gender, clinical risk factors, including the behavior, disease, and the relevant guideline will likely to become more specific service of population. Genomic testing has the potential for the guiding personal recommendation for screening and prevention, but the currently available genomic screening in average risk individual is limited by an incomplete understanding of the predictive value of specific genotype in general population. The uncertain effect of such information on the clinical decision and concerns about the possible adverse effect of the screening. So with all this, I would like to conclude my talk. Thank you very much for the patient listening, and very, very sorry for the interruption which I had faced because of the internet. I apologize for the same.
May I?
Yes, Dr. Abhilash.
Yeah, hi.
Thank you for your excellent presentation. You've outlined the various guidelines which are recommended by US Recommendation Force in prevention and screening of common diseases like metabolic disease, neoplastic disease, and also diseases related to mental health and drug abuse, alcoholism. But I would like to stress that in the Indian context, I think we should give a lot of impact on in preventing metabolic disease, which has come as the leading killer in our Indian patients. So I think if you could highlight a little bit more on the diabetic screening and the screening for cardiovascular diseases, that would have been more
Yes.
relevant because in our settings, that is the leading cause of death in our
So,
Indian population. It is suppressing neoplastic diseases and cancer in a big way. And so I think we'll focus more on
yeah,
that.
true,
But,
true.
I think
I
there
would
are
like to
some
add
more
a word,
questions.
friends. Yeah. In the beginning only, I've said that I'll be talking about the A grade recommendations and the B grade recommendations which we have received it. As far as the Indian contest is concerned, I do agree with their concern that before the age of 1985, we do not have much of the metabolic cases here in our part of the world. Now we are increasing. The only data which we have, or I have with me, as per the Indian the metabolic diseases are concerned, that the weight reduction is the primary important impact in reduction of the metabolic diseases. 1%, even 1 kilogram of weight reduces 15% of the incidence of new diabetes. So this is very important. An ideal body weight and low sodium diet and a healthy lifestyle. It was one of the very shocking data which I have received is, every one of us, including the doctors who are sitting right now here with me, just go home and check as per your height whether you have an ideal body weight. We have found that more than 90% of the well-educated class of the people we so-called are often overweight. So this is one of the reasons. So definitely we must look into the lifestyle issues much more.
Vilash,
Thank you.
Vilash, this is Dr. Shah. Thank you very much, Vilash. I would like to ask you one thing about, and I would like to add also one thing. Regarding the BMI, just now you said, but I think rather than BMI, we are thin, fat Indians
Fat
because of
Indians,
visual fat we have.
the concept of thin
So
fat
I
Indians.
think the waist hip to hip ratio is a better predictor than the BMI itself only. So we can go for that one thing, and the other one is I want to ask you one thing about the isoflavors. I do not know whether it comes under your your topic or not. The use of isoflavors in the in postmenopausal women. So do we have any gynecologists over here?
Yeah.
So
Yes, Dr. Roy, I can answer that
yes, sir.
for you
Yes, sir.
briefly. In postmenopausal women, there is no definite scientific proof that isoflavins have a role.
Okay.
No, it is only a placebo effect till now,
Okay.
and there's no definite role for isoflavins, but it's recommended widely and used widely by general practitioners and gynecologists, but none of the guidelines recommend for that.
Okay. Okay. Sir. Thank you. Thank you so much. Thank you, sir.
Dr. Abhilash, just a few questions and a few comments to make here.
Yes.
First of all, regarding the Indian scenario, there is actually not a very old, I think came out in 2018. There is an RSSDI, Endocrine Society of India guideline on diabetes and metabolic syndromes. It's quite an exhaustive guidelines, but a few things which we have to mention here, which are very worthwhile here. The role of statins in Indian diabetes patients is much more important than what you find in the Western audience. Nowadays, even in the ADA guidelines, you find that you give statin as a routine treatment in any diabetes patients.
Yes.
And you try to keep the LDL levels at a much lower level than what you'd go for a non-diabetic patient. So that's issue number one. So there is no dispute regarding the use of statins, and you can start them even if the patient has got a normal lipids. So that's the first thing. Second thing is regarding the waist-hip ratio, which Shayak touched briefly. Nowadays, we don't go for a waist-hip ratio. We have become much more specific. We go for the waist circumference. The waist circumference is actually a much more specific way, and there are specifically ethnicity-specified criteria. For Indian patients, if it's an Indian male and the waist circumference measured at the level of umbilicus is more than 90 centimeters, that fellow is obese. For an Indian female, if it's more than 80 centimeters, that lady is obese. So that's a simple definition right now, and this has come from the famous why paradox. You must have seen that thing several times in many presentations. the Yudkin-Yagnik paradox. Both of them had the same BMI 22.5. But Professor Yudkin, who was an American gentleman, his body fat, as measured by MR scanning, was much lesser than that of Professor Yagnik, who's, as we all know, very famous diabetologist from the city of Pune, who has done some fantastic work, and one of the few doctors who was given this honor of a plenary session in the annual conference of the European Association for Study of Diabetes. And where he has got his theory on the fetal origin of diabetes, where again obesity is one of the presenting factors which can actually lead to the development of diabetes. So these are the few things which I feel should be worthwhile when we're talking about the Indian scenarios. The other important issue, and I'm not sure whether we've got any cardiologists in the audience, there was one big study done across the 4 metro cities of India. This was around 20 years ago. And they found out that the risk of a coronary involvement in the different cities is actually different. For example, it was found that the people from Calcutta, I prefer to use the word Calcutta and not the disgruntled Kolkata. Calcutta people, they have got a much lower coronary artery dimension compared to somebody in Delhi, for example. This was a very big study where they actually measured the coronary artery dimensions of around 100 people from each city. So this is something which is also very important when you have to take about, because we all know that diabetes is a cardiometabolic disorder, and it is a cardiac myocardial infarction risk equivalent. So that's it. So basically, you have to give them the full protection from any cardiac onslaught.
Just a quick comment from my side. We're nearing the end of this session, actually. Just you mentioned about the colonoscopy screening. And as you all know, in Indian context, it's also less relevant and impossible, like West in US, because the incidence of colorectal polyps, multiple polyposis coli, and colorectal cancer is very low in India. We can see it from the text as well as from a practical experience. And also in practice, it's difficult to follow over 50 screening or over 60 screening at present kind of pattern. And that's number one. Secondly, hepatitis B vaccination also there is a controversy regarding how to proceed. I think rather than blanket vaccination, if it can be identified, then it's much easier to get the information whether the patient has positive or negative, rather than blanket vaccination institution or a community. In a patient community that we live, we can afford to do a test rather than just doing blanketly. Okay, thank you. I think that's.
Yes, thank you.
Right. With that, we end
I think we can conclude
the
this
session. With that, we end the current session, and we move on to the next session, which will be the one done by our dear Dr. Sudip Basu. He's a consultant gynecologist of the city. I've known him for the last nearly 30 odd years. And can we have Dr. Sudip Basu's slide?
Now, before that, I think Vinu, you can hand over to Dr. Vinu.
Yes, I'm doing that. I've not yet finished.
Yeah, okay.
I'm not yet finished. So basically, and he will be talking today. And the chairperson for today's session is Dr. Vinu Balkrishnan, who is basically has got teaching activity of several interesting places. He's a senior consultant obstetrician and gynecologist at the Kerala Institute of Medical Sciences in Kerala. And he's got the faculty for training of the Part 3 of the MRCOG examination completed. He has got clinical teaching experience, the UGC undergraduate in the CUH, and postgraduate training at the KIMS Hospital. So quite I should say, an impressive CV. And without wasting much more, can I just invite Dr. Balakrishnan to kindly take over from here. Dr. Balakrishnan, please unmute yourself here.
Thank you, Dr. Sujoy. I just shared my screen regarding Dr. Sudip Basu. Dr. Sudip Basu is currently the medical director of Srishti Clinic. He finished his postgraduate studies in 1991 in India, and then had his both membership from the Royal College and also from the Royal College of Ireland. And he finished his membership by 1998. He has completed his specialist training, which was quite a prestigious one, by 2007. And he got trained in all the prestigious institutions like St. Thomas and Guy's Hospital, London, Royal London Hospital, and he was a senior specialist registrar in the University Hospital, Wales. He has 7 publications in his credit and numerous research articles. He has more than 40 paper and poster presentations up in his arms. He was an invited faculty in more than 20 national and international conferences. He is, apart from the medical director of the Srishti Clinic, Calcutta, is the lead infertility consultant at AMRI group of hospitals, and he has a special area of interest is ultrasound and endoscopic surgery. Dr. Sudhi Basu will be talking about polycystic ovarian disease, which is a heterogeneous endocrine disorder which affects 1 in 15 women worldwide. It's basically hyperandrogenism and also with the insulin abnormal sensitization. It affects almost all ages of women, from the neonatal to the postmenopausal. It's an area of interest for neonatologists, from pediatricians, to the adolescent medicine, to a gynecologist, to an endocrinologist, a physician, and a nutritionist. And now, in the recent, in 2020 reproductive article of in August, a study has shown that even the adolescent girls having a neuropsychiatric problems if their mother suffering from polycystic ovarian disease. So Dr. Sudhi Basu will be discussing more about the diagnostic and therapeutic modalities of polycystic ovarian disease, because the diagnostic criteria used by different specialties are different, from the Rotterdam to the European consensus. The way a endocrinologist looks a woman with polycystic ovary may be different the way in which an infertility specialist will see. So Dr. Sudhi Basu will be talking more about current diagnostic and therapeutic dilemmas of polycystic ovarian syndrome. Dr. Sudhi Basu, the stage is yours.
Thank you, Binu. Can you hear me?
Yes, I can.
And can you see the screen as well?
Yes.
Okay, thank you. Good evening and Happy New Year to all. And it's a pleasure to meet all my friends and dignitaries. What definitely...
Excuse me, Sudeep, we can't see you.
Okay, you cannot see me.
No.
Can you see the screen? Can you see the screen?
I mean, I think it's visible. It's very well visible here.
We were able to see him.
No, I think we are able to see him. Yeah.
We can also. I think we can all see him. He's pretty well visible here. And audible as well.
We carry on, please.
Okay, thank you. Thank you very much again. So I know some of you, and to start with, why I chose this topic. That is very important. Initially, I thought that I'll talk about micronutrients in PCO, which is a hot topic nowadays. But I realized that I should talk about something which I face every day. I have got an infertility clinic, and approximately I see 25 to 30 patients every day. And 1 in 5 patients come to me with a diagnosis of PCO. Sometimes they come from the district, sometimes they come from the other centers of Calcutta. Now, many times I have seen, after doing the ultrasound and taking the history very carefully, and believe me, I have often find out many of them do not suffer from polycystic ovarian disease. And that is very frustrating. That is very frustrating because many of them actually suffering from a premature ovarian failure, and they are being treated with the diagnosis of PCO for last 5-6 years with the metformin, letrozole, tomifene, micronutrients, and whatnot. And when they come to me for the treatment, and I find out their ovarian reserve is almost at the basal level, and I have to offer the egg donation as an alternative because they will not get pregnant with their own egg, it is very frustrating for them. It's very frustrating for us. So I used to always think that where we are going wrong. the basic problem is we're going wrong because we cannot send our messages very clearly to the district consultants who are the first point of contact for these patients. It is unfortunate that this today's meeting probably is not being attended by them. But even if we take up the message today, what we discuss and agree, then probably we'll be able to put some benefits to these patients. So where is the problem? Where is going wrong? Now, the biggest problem with the polycystic ovarian disease is that it's a multifaceted disorder. And believe me, till now, every day, there are more information are trickling on PCOS. So in India, we have got a polycystic ovarian society who hold the conference for 3 days, attended by more than 100 delegates, and then go home without having any conclusive message that what to do with these patients on the next visit. So it is so frustrating. So because the problem with the PCO, we do not know where we should blame. Where is the starting point? Is it the ovaries our starting point? Where the ovary ovulations are not happening? Sorry. So we can see the ovaries where the follicles are being mistaken as a cyst, or we should blame the patient for the obesity, we should blame androgen excess, or we should blame the insulin resistance. So it's a spectrum of manifestations affecting not only women of childbearing age, but more and more we are seeing patients from the adolescent and even some patients in the postmenopausal women, surprisingly. I'll discuss later on. The polycystic ovarian syndrome, again, this is PCOS. Okay, polycystic ovarian syndrome is associated with anovulations and leading to oligomenorrhea or amenorrhea. And traditionally, obesity, increased androgen with symptoms of abnormal facial and skin hair growth. We call it hirsutism. In pregnant women, can go back to the preeclampsia, early pregnancy loss, and some patients even endometrial cancer. No doubt, in our infertility unit, this is one of the leading cause of fertility problem. Now, what is the global incidence? The global incidence is varied from study to study, and again, because of the background populations, the populations or the patients attending the clinic, and different phenotype, but it can be as high as 25 to 26%. Surprisingly, which is very interesting, that Chinese people with the lowest incidence. No, to speak very frankly, I have not seen many obese Chinese. Probably they are very fit, and that is why polycystic ovarian disease is less common in this group, especially obese PCO. Now we have to see whether the lean PCO is more in them, but definitely their incidence around 4 to 5%. In my patients and most of the infertility clinic, it can be 1 in 4, but more or less, his adolescent group is 8 to 10% is on the rise. Every alternate day, I get some frustrated parents are coming with their girl slightly obese, telling she's not having period, she's grumpy, and she's getting weight, she takes junk food, so do something. Now, PCOS studies have been done quite extensively in India. And believe me, in all the infertility conferences, at least few sessions is given to the PCOS. So you can understand from the right-hand side, the prevalence rate is again probably around 5 to 22%. Now, I just, sorry. So what is the difference between PCOS, PCO, and PCOM? So polycystic ovaries is basically looking at the ovaries where you can find the small black area covering the whole of the ovaries. Okay, traditionally people used to call it cyst, but it's not cyst. It's the follicle which are looking. Ideally, one of the follicle will get bigger, will become dominant, and then ovulate. Okay, that happens with the ovulations, with the hormone changes. The endometrium gets thickened, gets secretory. If the embryo doesn't get implant, then it gets slapped out as a period. So that is the basic physiology all of us know. Now, when along with these findings, we find out oligomenorrhea or amenorrhea along with androgen excess, and then we call it polycystic ovarian syndrome. Okay, so it's very important you can understand that whether it's a PCO or polycystic ovarian morphology, that a new terminology is coming based on how you do the ultrasound. Diagnostic criteria, so depends on symptoms, ultrasound, and biochemical parameters. Now, what are the symptoms? Does all PCO patients in the reproductive age group present with infertility? Are all of them present with hirsutism? The answer is no. Around 70% of the PCOs might present with hirsutism. 20% of the infertility patients may be diagnosed with PCOS. So all the PCOS patients is not infertile, and all the infertile patients are not PCOS. 80% of the patient who is suffering from oligomenorrhea and amenorrhea may have polycystic ovarian disease. Okay, just because they have got oligomenorrhea and amenorrhea, and on the ultrasound, it looks a little bit of increased follicle count, that doesn't make them PCOS. What happens in our practice, that a patient suppose comes at 36 years of age for an ultrasound in the district. The person does the ultrasound from the abdomen. He looks at the ovary, which is a frustratingly small size. Then he asks the questions, are you having normal period? Now already she's having spaced out period because she's approaching menopause. So immediately, believe me, immediately many ultrasonologists diagnose as a case of PCO. And goes back to the gynecologist. The gynecologist starts with metformin or the other micronutrients, start giving them ovulation inductions, roam around. They come to me at 40 years of age, and there's absolutely no eggs left. That is the biggest problem. You have to look at the whole picture. Obviously, increased androgen excess can present with the acne, skin tag, hyperpigmentation. You know better than me. Sometimes these patients go to the skin specialist as well. Now, adolescent patients, depending on how obese are they, 4 to 25% might be suffering from PCOS. Now, because nobody could agree what should be the diagnostic criteria, the members of the different society, they used to fight all the time. They used to tell, no, you have to take these patients for this PCO. Somebody told, no, I don't agree with you. Now, as something good happened a couple of decades back, in 2003, in Rotterdam, all these people assembled, told it cannot carry on. So why don't we come with a consensus guidelines which helps us to diagnose PCO? But that was clearly different from the people of the Endocrinology Society, or sometimes the society which push on androgen excess and PCOS. But more or less, they believe now that 2 out of 3 should be present in a woman of the reproductive age group to diagnose a case of polycystic ovarian syndrome. So it has to be polycystic ovaries diagnosed by ultrasound. Ideally, this ultrasound should be transvaginal scanning. The reason is that with the transabdominal scanning, the picture quality is not good. You have to have very, very good ultrasonologist, and you have very, very good machine with a proper resolution setting. But in TVS, It's much more easier. You can see better. I'll show you some pictures later on. Okay. Now they come out with this criteria in 2003 that it have to be 12 follicles in each ovary of size 2 to 9 millimeter. That's the pre-antral follicles. Okay. These pre-antral follicles will get recruited later on. And the ovarian volume should be 10 cc or more. That's fantastic. But they again changed the goalpost. Couple of years ago, they told, no, we don't agree it anymore. We have to include 20 follicles of 2 to 9 millimeter size in each ovary. And since then, quite a few studies have done with these two criteria and find out with the new diagnostic criteria, you are going to lose out almost 20 to 25% of the PCOS patient. And that's getting more interesting. Now, how it looks like the image comparisons. So you can see the first two is the trans-abdominal ultrasound. So you can see this ovary abdominal ultrasound is pretty convincing. It's a PCO probably. But many ovaries on the abdominal scan is not so good. Unfortunately, it's a very small ovary, is 4 to 5 cc total volume, and you can hardly see any follicle. But comparison of see the third one you can see, it is a transvaginal scanning. And these are the small follicles you can see. In the past, what the people used to think, that have to be in the periphery, it have to be thick stroma, the stromal blood vessels have to be increased, put the Doppler. Nowadays, to speak you very frankly, we don't go by these short nitty-gritty details. If the more than 12 follicles, according to new criteria, 20 follicles, even scattered throughout the ovary, small follicles you consider is a PCO. Now, the people understood, again, the variations of the scanning abilities. So with the machines of the, especially a GE company, I'm not advocating GE, but they could definitely do very good ultrasound machines, especially for option gynae purpose. And with the new software, they told, okay, hang on, we reduce your problem. So nowadays, you just put the 3D on and you come with the Suno AVC, which will calculate how many follicles are there. So you don't have to do anything. So the 3D modeling, picking out every fluid filled area. Now, if it is just a retention cyst or simple cyst, even it's a tube ovarian mass with the hydrosalpinx, it will show the same picture. So probably you are going to reduce the subjective inter-observer variation, but that's never going to be zero, I'm afraid. Now, alternative. Have we got anything that I don't want ultrasound? Can you give something more? The people tried in the past FSH-LH ratio. So the LH and FSH ratio will be altered. LH will be more and FSH will be less. So usual 2:1 will be 1:2 now. But unfortunately, it doesn't work for all PCO. Many PCO patients we have seen, it is same. Okay. So does that rule out? So we understood it's not so reliable. And unfortunately, an FSH-LH actually goes on cyclical variation. So in this particular cycle, you think, fantastic, I diagnose PCO, but you do after 3 cycles, you find out, no, it's not same. Now, AMH. So people come out anti-Mullerian hormone. My next slide will be a little bit more information on that. And obviously, the other findings to find out other biochemical parameters. So AMH or anti-Mullerian hormone, also known as Mullerian inhibiting factor, is a glycoprotein structure related to inhibin and activin. Now, in embryonic life, AMH is very critical for sex differentiation. In the male, AMH is high, so that's why they don't get female gonads. Now, in obviously post-embryonic life, the AMH is a product of granulosa cells of the pre-antral and small antral follicles. So that means if there are more pre-antral antral follicles, the AMH will be more simple. So that is why if the PCO has got 20 follicles and everyone is secreting a little bit of AMH, the total AMH will be very high. So it should be hunky-dory to find out, oh, bingo, we have got the magic word to say this is a PCO or not. So AMH serves as a molecular biomarker for follicular reserve. And that is the reason we found that it might be helpful to diagnose PCO. Advantage is not subjective. Whether I can do scan or not, it doesn't matter. I'll just take the blood and send it to the nearest lab. So yes, it is usually higher in PCO women with menstrual irregularities and androgen excess. So it is higher in PCO women with menstrual irregularities and androgen excess. That means you're already creating your own group which will going for the PCOS. It is non-invasive. The advantage is that it's relatively stable throughout menstrual cycle. For the FSH, LH, you have to do in the first 5 days or 6 days. But AMH, ideally you should do during that time, day 2 to day 6 of the menstrual period. But if the patient comes on day 10, 12, you still can do it. Sometimes the results are variable because of the old test reliable assays and lack of international standards. That is why sometimes you will find out some of the instrument company lab will come, sir, you have to use this machine with this reagent, and then only you can tell whether the image value is validated or not. The biggest problem is that we still have not been able to reach the internationally agreed cutoff value, above which we can call it a PCO. No, many patients, believe me, come with the result. And if they follow the American standard, it is written 1 to 15 normal. Even the patient is going for ovarian failure or PCO, patient will tell, sir, the range is so big, I'm falling in the range. Why are you calling it a PCOS? That is the biggest problem. We still, after so many years, we still could not tell, okay, above which we'll definitely call this a PCO, and below this level, we'll definitely call this not a PCO. Another problem is that sometimes the lab which you use, or the patient you are using, or the reagent you are using, it comes with a different unit. So be very careful about the picomole per liter or nanogram per liter. My PGT training actually made quite a few mistakes sometimes, telling that this is not a PCO, but I found the range what she is looking and what she's thinking is completely different. So please be very careful. So AMH, okay, probably AMH and ultrasound can complement each other, okay, but it's not going to be exact alternative. I still believe personally that if we do a good ultrasound scan, sometimes you can negate, okay, the completely dependence on the AMH. The evaluation of androgen excess. Now, we are going to another unexplored territory. Okay, so to diagnose PCO, fantastic. We need to diagnose the ovaries looks polycystic. Polycystic is a misnomer. You have to take history for the androgen excess, clinical examinations, find out hyperpigmentations, hirsutisms, little bit of hair on the upper lip, hair is going beside the cheek. Sometimes you ask in between the breast, pubic hair, everything. You take a detailed history, or you ask her mother. Now, the free or total testosterone, if it is an ovarian tumor, androgen secreting obviously is going to be high, but it will be too high. So free or total testosterone can be another diagnostic criteria to find out. So if you think you are dealing with the PCOS and you really want to know that they have got androgen excess or not, you have to ask for some biochemical test. Routinely, we do not ask for dihydroepiandrosterone sulfate, but if you're too keen, sometimes it also costs money. Which lab you're doing, sometimes it's not available in the district. They send the sample to the city where you have to be pulled, and then you get the report after 15 days, 20 days, 30 days. We do not know. So it's sometimes difficult. But if you think that, yes, I cannot differentiate definitely with confidence that this is a PCOS or something, you can ask for a city, or you can ask the help for your endocrinology friend. I am very good relations with most of the endocrinology friend in Calcutta. And if I run into trouble, I always ask, Sujoy, can you help me out, please? Now, is all PCO is obese? The answer is no. In the past, we never believed that lean PCO exists. But nowadays we know that if I take 100 PCO patients, probably 66, 70% will be obese, but believe me, 25 to 30% will be lean PCO. So I'll talk a little bit about that, but not much. Now, I was reading that why these obese tissue and lean tissue. That is because, you know, I'll probably cover with the next couple of slides that there's more and more evidence that it is a genetic predisposition disease. Now, which gene will be expressed, in the ovary or the endometrium or the fat, it also depends on that, whether it will be lean tissue or obese tissue. So they have done, not many studies have been done, they have done the study on the obese tissue and lean tissue and find out, though there is overlapping some of the genes, but also the expressions of the gene is different in case of obese tissue and lean tissue. Now, obesity obviously poses increased risk of developing impaired glucose tolerance in overweight obese women with PCOS when compared to the normal young women. Incidence of dyslipidemia also increases with increasing obesity. Now we are going in a very favorite territory of both Sujoy because they love metabolic syndrome. So you started with a diagnosis of the ovaries, whether it's polycystic or not. You tried to include the androgen excess, and then you included whether they're obese or not. You start investigations. You call the ultrasoundist, Dada, can you do a little bit of a liver scan? They found, my goodness, it's fatty liver grade 1. Now, what I'm going to do? The problem is now, these are complex pictures in front of you, okay? So studies on PCOS from India reported a prevalence rate of 37 to 62% for obesity in patients with PCOS. So, as I understand, obesity poses increased risk of developing impaired glucose tolerance test. Now, how I'm going to find out, tell me, how I'm going to find out whether these patients has got insulin resistance and impaired glucose tolerance test, okay? Now, I have asked these questions to all my gynecology colleagues, both young, a successful practitioner for 3 decades, and believe me, there's no uniformity. Some do hemoglobin A1C fasting blood sugar, some do glucose tolerance test, some do fasting insulin, and some doesn't do anything and start metformin. That is the biggest problem. Till now, though there is some tingy-mingy guidelines from our societies, but definitely we do not need, unless you do these things and stamp them, yes, they have got impaired glucose tolerance test, can we start the medicines or not? Incidence of dyslipidemia obviously increases with increasing obesity. Now, sorry. So symptoms of PCOS with obesity, and I'm not going, it's all in front of you, you can understand. What is the biggest problem we know? The people look at the patient, give them the advice that you have to cut down carbohydrate, you have to lose weight, you have to be positive, you have to start metformin. The problem, I'm telling you, the most of the time, they don't look at the psychological aspects. A patient who is PCOS, who is obese, not menstruating regularly, is going from door to door for the invalid treatment, eating more out of depressions, now getting depressed, going to the psychiatrist or antidepressants is a vicious cycle. It is a vicious cycle. To come out of the vicious cycle, as a clinician, what you have to do, you have to come out your comfort zone as a gynecologist, as an endocrinologist, and you have to give them the confidence, we have done the diagnosis. I know you can do it. Let's start it. And if that, you have to do a little bit of psychological counseling. I'm fortunate in my clinic, we have got a fantastic counselor who got the initial training from me, but later on, she started getting more and more research evidence, educations from different societies now. She's a fantastic counselor. And we do the clinic combined with gynecologist, if necessary endocrinologist, with the counselor, with the dietitian. And we call it a PCO club. And it's works wonder. The only entry to the PCO club that you don't need a big packet of money or big money bag. The only criteria you need, you have to diagnose PCOS. So that is your passport. I call it a very elite club. And then you sit down with them, you call the physiotherapist, you tell them how to do exercise at home. You don't have to go out in the park with your big jogging suit and start running and getting out of breath. You can do in your house. And many patients have got tremendous benefit from this simple treatment of PCOS club. But it's my misfortune that I could not replicate to any other part of the city or even in the district because they do not want to come out of their comfort zone. It's much more easier to give 6 months of letrozole or clomifene or metformin. Bye-bye. I see you in 6 months' time. Okay. So I think the time has come to think a little bit differently. As I told you, insulin resistance, science, as soon as I read about it, I tried to go and put the measuring tape around my waist and I found it's 36. Now I said the site of belief, probably not yet. Okay.
Dr. Sudeep, sorry
Yes.
to interrupt. We have short of time. I hope.
Okay, I'm just going to finish it. Okay, just a couple of slides. No problem. Sorry for this. Okay, now you have to read more about this HOMA-IR, fasting plasma glucose measurements. Treatment options for PCOS, I'll not take much time. So your idea is to either to regulate the menstrual cycle or for ovulation inductions. For the regulation of menstrual cycle, you can put lifestyle changes, you can give progesterone therapy or contraceptive pills and continue contraceptive pills. This is no side effect. Don't stop suddenly because they will go back to their old norm. For ovulation inductions, clomiphene citrate and letrozole has done wonder. It takes sometimes long time to find out the dominant follicle, which can develop even though day 18 or 19. Letrozole actually works better. Metformin alone actually fared less than letrozole, but sometimes we combine with gonadotropin or letrozoles. Treatment options for PCOS, again, the last I want to mention that if you find out nothing is working to reduce weight, the last option actually nowadays suggested by the society is that you can consider for bariatric surgery. So previously it was a big no-no. Nowadays the people telling you can consider is okay. Laparoscopic ovarian diathermy, you do 3 or 4 diathermy points in the big ovaries, and sometimes the resistance to the medicines actually get reversed and they start normal ovulations. Micronutrients, there's a big debate going on. The jury is still out whether we should use inositol, myoinositol, BCI, whether we should keep 40:1. It has, or it is showing some promising result, but probably a few more years have to pass before we take it a call. But the patient who is not responding to letrozole, not responding to the metformin, we have found that sometimes the micronutrients is actually working. So don't be too innovative to use it. Nowadays, the medicines are widely available. Laparoscopy, I think Bhinu will suggest this is basically is called rule of 4. It's 4 points, 4 millivolt, 4 points on the ovary. Don't do too much. If you see the last one, they have done so many micropunctures that when the patient will come to us, they have destroyed most of the ovary. It should not happen. The bariatric surgery, the more and more studies is showing that sometimes it can help the PCOS patients who are otherwise failing to reduce the weight and getting the normal weight and ovulating and fertile. The common myths, this is last part 1 slides. So there is familial predisposition genetics. So really you are not to blame. Whether you will have the PCO or not, probably is determined when you are an embryo. The may start normal cycle once older. That is a myth. The PCO is always a PCO. What happens if the medicines they ovulate, the sooner or later, probably all the follicles are getting exhausted. So sometimes it is true, very few of the patient will start normal period at some point, but that is not going to stop you for giving the treatment. Get cured once married. I have seen many gynecologists telling that there's no need for the treatment, go and marry, everything will be fine. No, it doesn't happen like that way. Can be cured by medicines? No. You can only treat the symptoms. The PCO itself, the condition cannot be reversed. Lifestyle, junk food. The one thing I want to mention is not simple calorie in, calorie out. Even if you do the lifestyle modification for the obese PCO, they find it very, very difficult to lose weight. 7 to 10% weight they will lose, then they will stop. And at that time, the motivation needs requirement. So probably this group of patients is slightly different for another obese patients who can reduce the weight just by doing dieting and exercise, but they should continue the effort. That is my last slide, and thank you very much for patiently listening. Thank you.
Thank you, Dr. Sudeep. That was an excellent and comprehensive coverage of polycystic ovarian syndrome. There were a couple of questions came up. Actually, it was from the panelist itself, from Dr. Ray, and the question was, what was the role of metformin? Probably in the latest slides showed. Can you just explain what is the role of metformin in the treatment?
Yes.
Because Dr. Sahayak Roy was asking the question.
Okay, so initial enthusiasm about the metformin as a magic drug has gone. Okay, so metformin should not be used for all the patients. It doesn't do any good. If you want to use it for ovulation induction, the metformin actually fares less than the aromatase inhibitor letrozole. If you use the metformin for the
phone karo ঠিক আছে বিজন থেকে ফোন করো
If you use metformin for the weight reductions, that should not be the starting point. You should always start with the lifestyle modification and other ways to reduce the weight. The metformin can be used with IVF, that reduces the chance of ovarian hyperstimulation syndrome, but whether it improves the egg or embryo quality, it is debatable. So basically, metformin should be used for those patients who have definitely confirmed a carbohydrate metabolism problem.
Sudipta, just a question. I mean, how frequently do you use the anti-Mullerian hormone assessment before you are starting any patient on a fertility treatment, of a PCO patient on a fertility treatment?
That is a very, very interesting question. See, I'm doing ultrasound from 2001, and I used to teach ultrasound to the people from all over the country. So I believe in my more ability. So I have found it 80 to 90% cases, believe me, if whatever predictions of the image, it will come like that. In 5 to 10%, actually there's a disagreement. So for the IVF, I actually depend more on my ability to find out how many Antal's follicles are there, because that will guide me what will be the starting dose of gonadotropin. Are we going to have the ovarian hyperstimulation syndrome? So I believe more my scanning ability than image.
Dr. Sudeep, one more last question. It was from Dr. Manojit. This is about the lean management of lean PCOS. He was keen about how to manage not obese, lean PCOS.
See, lean PCOS, in those cases, you cannot tell them to reduce the weight. If they reduce weight, they will disappear. Okay, they're thin. Okay, so basically, you have to do ovulation induction with letrozole and clomiphene. If they still suffer from carbohydrate metabolic problem, then you can start metformin, but many of them actually do not have. But if they again come for the ovulation induction for IVF, I go with the standard gonadotropin. If they're keen to try anything else, sometimes if I do the laparoscopy for some other reason, I do the laparoscopy of drilling as well. Now you have to understand that the rule I completely follow, that if they have getting regular period, okay, but the PCO, it looks PCOS on the ultrasound, but they're having regular period and they might some other features, then usually I don't do ovarian drilling, because I believe that that is going to cause much more problem when I'm going to do assisted reproduction treatment.
And he again asked about micronutrients. Can you just briefly go through, because we are running very late, I think Dr. Raya is correct.
Okay, I'm sorry. Okay, very worried. Okay, see, nowadays I was dead against using micronutrients, but I found many of my friends have started using it, and they told they're getting the results, good results, regarding their starting normal period in those patients where actually metformin or letrozole has not worked. So I told, okay, no harm, start giving some micronutrients, because at the end of the day, most of them is basically vitamins and vitamin B group. The basic problem, what the medicines available in this country, that every company comes with the completely different proportions. But if you understand that myoinositol and DCI have to be in the physiological ratio, because if these patients suffer from the insulin resistance, there is a problem to convert into the inositol. That's why ideally they should be given, but most of them usually come 1,200 come inositol. I have started using it and I'm getting actually better result, a small group of patients where I could not make them ovulate. So in those patients, what I've started a study now using them before IVF and finding out whether that will make them the better egg quality or embryo quality. I need a big group.
Thank you very much. And that we'll conclude at this talk and we'll go to our Master of Ceremony, Dr. Manjuta.
Thank you.
Thank you, Dr. Basu and Dr. Balakrishnan for excellently running the session. I'm afraid we are running short of time, and the last speaker of today is Professor Rangaraj Setlur. And to introduce him will be Dr. Bijan Bhattacharya. I think he has just joined probably. I request both the speakers and the chairpersons to kindly stick to the time as we are running pretty late. So,
actually, Dr. Bhattacharya got disconnected and called me. I think while he trying to get connected, I think we should proceed. He was there for a long time, but something went wrong in his, I think, and he is still trying to come. So perhaps without further delay, we can just get started, and then he can join in later on.
And I can only assure you, Professor Setlur is going to tell you about what the consultant, and this is something very important for us because as physicians, when we refer a patient for a surgical procedure, and we all know that anesthesia is an integral part of any surgical procedure. Now, before a surgical procedure is done, the anesthetist needs to get certain medical informations about the patient. And what exactly he wants to know, this is something which will be divulged by Professor Setlur. Those of you who have heard him before, he actually is an excellent speaker. And I'm pretty sure this is going to be a very interesting talk. Well, over to you, Professor Setlur.
Can you hear me?
Yeah, you're audible and visible.
Okay, great. Hi. So I'll just go through this as quickly as possible because I'm sure you've got the rest of the night to catch up on. So why this is important is because in my experience, the problem with Indian doctors isn't that we don't know what to do, it's that we don't talk to each other. And all of you have seen doctors who will come into the ward and write a note and walk away without talking to the MO in the ward. Or specialists will come and write a note which is completely contradictory to what the previous specialist wrote and not bother to pick up the phone to sort of sort out this confusion. Or doctors who have had a fight with each other 10 years back and spend the next 10 years not talking to each other in the hospital. So we have all been through this, and it's important that we break down these walls so that we communicate to each other. So let's just talk about what isn't particularly helpful if an anesthetist refers a patient to you. The first thing is there's not much point in writing avoid hypotension and tachycardia or things like that, because anesthetists constitutionally spend all the time trying to keep the values within normal limits. So telling him not to let the patient get hypotensive, that's something he's not going to do anyway if he can at all help it. It doesn't help for you to advise him on what technique of anesthesia to follow. And here, I'd just like to editorialize. When I went to specialize in intensive care about 20 years back, it was because I thought that anesthesia wouldn't change at all, and intensive care was the place where all the advancement should happen. I couldn't have been more wrong. Intensive care has been circling the same syndromes for the past 20 years. Anesthesia, on the other hand, has changed completely out of sight. It's really unrecognizable from 20 years back. And the advice which you give might not reflect the way anesthesia is practiced nowadays. It's changed so much. The third thing, which is a little problematic, is it doesn't help much to say that the patient is fit for surgery. I know that very frequently anesthetists do refer patients for fitness for surgery. I don't think they understand that what they're doing is actually fairly stupid and is going to get them into medical legal problems. Because if the specialist writes, let's say you send the patient to the endocrinologist and he writes for diabetes control, and you write fitness for surgery, and he writes fit for surgery, he's not actually looking at the patient as a whole. He's not looking at the patient's airway, the patient's risk of bleeding, the patient's risk for having an intraoperative event. But since he's written fit for surgery and you've asked him for fitness for surgery, something goes wrong after that, then you're in trouble because you asked for fitness for surgery and a specialist said that you're fit for surgery. That implies that anything which goes wrong after that is your fault. What else isn't particularly helpful is ordering a battery of undirected tests. Now, Dr. Tiwari alluded to this in the first talk. it doesn't help to do routine screening if you've got a low probability of a positive result. And this comes down to a mathematical theorem called Bayes' theorem. I won't go into the mathematics of it. I'll just give you an intuitive, brief summary of why it doesn't help. So let's talk about, let's say we do routine LFTs. Now there's two ways of doing LFTs. One is to do an LFT to everybody who comes to you, and the other is to do an LFT only when you suspect an illness, right? Now let's assume that you're doing it in an ERCP setting and you expect that 20% of the population is going to have a liver disease. And we can assume that LFTs will identify 90% of your patients with a liver disease, and they'll falsely identify 30% of patients with the normal patients with positive results, because LFTs do go up in normal patients as well. So a patient comes to you in a PA checkup and presents with a positive LFT. What's the probability the patient actually has a liver disease? Let's look at it. Okay. So you got 100 patients, and out of those 100 patients, 20% of the patients have the disease. So 20% of them, 20 out of 100 have the disease. Now, out of this, 90% of the patients with the disease will test positive. So 18 out of these 20 patients will test positive, right? But we also said that 30% of the normal patients will also test positive. So 30% of 70, right? So 24 will falsely test positive. Now, your chances of your patient having a disease is 20 divided by 20 plus 34, right? That's green over green plus yellow. So the chances of your patient having a disease is 43%, right? That is if you're doing it in a population where you actually suspect the patient of having a disease. Now, if you do it the way a lot of hospitals do it, which is to just order a whole battery of tests and hope for something to come positive, this is what happens. So let's say you're doing it in a general population, only 2% of the population is expected to have liver disease. And the figures are exactly the same. LFTs will identify 90% of patients with liver disease, they'll falsely identify the 30%. And now a patient comes with a positive LFT. What's the probability that the patient actually has a liver disease? Okay. So the patients who have the disease, are 2 out of 100, as we said, is 2% of the population are positive. And 90% of 2 is nearly 2. So those 2 patients will test positive. But 30% of the remaining 98 patients are also going to test positive, right? That's 30 out of 98, 30% of 98 is nearly 30. So your chances of the patient actually having a disease is 2 upon 30 plus 2, right? And that's 6%. So even if a person comes to you with a positive LFT, there's only a 6% chance that he actually has a problem. So the predictivity of a test goes down and the prevalence of the test is low. So there's no point in doing undirected testing when you get a consult. The problem is that doctors are scared of medical lawsuits, so they start ordering undirected tests. Now, how do you stop this from happening? How do you practice rational medicine? What you do is you formulate an institutional guideline. Dr. Tiwari spoke about national guidelines. Make an institutional guideline for yourself. For this, for instance, is the guideline which I've written for my hospital, right? It gives a battery of possible surgeries, a battery of possible illnesses, and tells what investigations are advocated for each condition. And we have given a copy of this to the pathologist, who can call up and say, why are you asking for investigations you know are not required? We have given it to the surgeons and said, we will not turn away a patient as long as you do these bare minimums. We will not ask for anything more unless there's a very good reason for doing so. Okay. And we have given it to the anesthesia residents and told them, you will not move out of these investigations unless there's a very good reason and you will ask us first. The same guidelines go for any drugs which the patient may be on. So, for instance, if a patient is on amiodarone, you'll ask for a pre-op ECG. If the patient is on anticoagulants, you'll ask for an LFT. If the patient is on anticonvulsants, you'll ask for an LFT. But we don't go beyond these investigations. And we have also told our residents who are sitting over there that there are only 3 reasons to refer a patient for a medical consult. Reason A is to evaluate whether further optimization is possible. Reason B is to consult for risk assessment in cardiology consults and pulmonology consults for gold 3 and 4 COPD patients. And reason C, because we are living in a poor country and very often the first time the patient sees a doctor is when he comes to the PA checkup room, and that's the first time he gets a proper general examination. So if you pick up an undiagnosed condition and you want it to be further followed up, then you can refer it to the physician. But it's important to write in that this is not going to postpone the surgery. Let's say you find a patient who's got a BP of 160 by 100. You want the patient to get treated, but you don't want to postpone the surgery. So we have told our residents, you write over there, referred for treatment of hypertension. This, however, will not delay the taking up of patient for surgery. So you're fulfilling your duties as a good doctor, and at the same time, you're making sure that the patient doesn't suffer because you've picked up an a condition which is not going to affect the conduct of surgery very much. Okay. So let's talk about a few cases where you can have a constructive consult between the anesthetist and the surgeon. Let's talk about case one. 65-year-old male had an MI 4 months back, and a drug-eluting stent was placed, and he was put on aspirin and clopid. He presents with a dull headache and early morning vomiting for 15 days, and we find that the poor man has got a large cerebral tumor with mass effect. The neurosurgeon says, I have to operate within a week, but I am not operating with aspirin and clopid, which no neurosurgeon wants to do because you're operating in closed spaces. And if there's even a bit of blood accumulating under the skull, the patient is going to cone, right? So the anesthetist refers the patient to you and says, to the cardiologist and says, can we stop antiplatelet drugs without raising the risk of stent thrombosis? And if not, what are our options? Now, this is a perfect consult, right? Because the anesthetist is asking about something which is an incredibly specialized branch of knowledge, which is that as the architecture of stents has changed, the guidelines regarding the individual thromboprophylaxis have changed. So the earlier drug-eluting stents, surgery was contraindicated for 6 months, but now they've come down to 3 months. And unless you know what type of stent is there, you can't really make any determination about whether it's safe to stop the aspirin and the clopid. Besides that, there are no clear guidelines on the subject. So it's very important to get the intuition of a specialist who sees these cases frequently. There are, in fact, a few case reports in which patients have been put on Cangrelor or Terafabin infusions 4 days, 5 days before. The clopidogrel has been stopped 2 hours before surgery, which is within 3 half-lives of Cangrelor. The patient has had the Cangrelor stopped. And immediately at the end of surgery, the moment the neurosurgeon was comfortable about restarting the case, the Cangrelor, the patient was restarted back again and clopidogrel. So this is a perfect sort of medical consult where you need the opinion of a specialist who sees these cases far more frequently than you. But if you are the physician or the cardiologist who's been referred this case, I would suggest don't just write a note. Call up the anesthetist, call up the neurosurgeon and say, let's have a roundtable conference. Let's all sit and talk together with the patient so that the patient understands the relative risk of stopping the antiplatelet drugs and the risks of waiting for 6 months for surgery, and let the patient go into the clear picture of what the risks and benefits of all the options are. Okay, let's move on to case 2. Case 2 is 65-year-old chronic smoker presents with the recurrent gallstone cholecystitis. Is a known case of COPD, minimally mobile, has a cough with copious yellow sputum, and has a preoperative saturation of 86%. The anesthetist requests risk assessment and optimization of the patient. Now, here the medical consult isn't that the anesthetist doesn't know what to do. It is that he's not geared up to take care of such patients. Such cases are best taken care of by a pulmonologist with a respiratory therapist, with a full lab support. And once the patient becomes stable, then the pulmonologist can say, I'm comfortable with the patient being taken up for surgery. Now I'm handing the patient back to you. Okay. So here the reason for referral is completely different. It's not that the anesthetist doesn't know what to do. It is that these cases are better taken care of by a pulmonologist, and it takes 3 or 4 weeks to stabilize the patient, which is generally not available to an anesthetist who's seeing multiple other cases. Okay. So what would the pulmonologist do if he got such a case? Well, the first thing he'd do is stratify the case according to the GOLD criteria, which all of you know about. The problem is that the GOLD criteria are extremely valuable for stratifying treatment. They're not particularly valuable for stratifying risk. For stratifying risk, there's another scoring system called the Icrcpi scoring system, which looks at the patient's age, the preoperative SpO2, whether there was any respiratory infection in the past month, whether the patient is anemic, what type of incision is going to be given. If it's an upper abdominal incision, the patient is much more likely to have postoperative respiratory failure. How long the surgery is going to last, and whether it's an emergency procedure or not. Based on that, you can give a far better scoring than you would at the GOLD. What else is the pulmonologist going to do? He's going to do stuff which is actually fairly routine but incredibly important. He's going to tell the patient again to stop smoking, consider giving antibiotics since he's producing profuse yellow sputum, optimize the patient's anticholinergics and beta agonists, consider stopping inhaled corticosteroids, work with the respiratory therapist to have pulmonary rehabilitation. Then the question is, should he do PFTs? Now you can do PFTs. Perhaps the most valuable thing on a PFT is to do an ABG and find the baseline PCO2 and tell the anesthetist, look, this is the baseline PCO2. Because if the anesthetist hyperventilates to a normal PCO2, the patient might not breathe at the end of surgery because he's got a PCO2 which is set at a higher level to stimulate his respiration. So if the anesthetist knows what the baseline PCO2 is, he'll hypoventilate the patient intra-op and ensure that at the end of surgery, the PCO2 is slightly higher than normal. PFTs don't help much in assessing cardiorespiratory reserve. What's far more useful is a 6-minute walk test, or even more valuable. Most of us have our operation theaters on the second floor. If I get a patient with a COPD, I'll tell him, look, let's go for a walk. I take him 2 flights downstairs and I say, let's walk back up. And if he can walk two flights up without any problems, then I know that he's fairly fit and he doesn't really require much more optimization. Case number 3, patient with chronic renal failure, serum creatinine of 2.5 milligram percent, urine output of 1000 ml in 24 hours, awaiting placement of an AV fistula. Suddenly, he presents with pain abdomen. They do a CT scan and they find that he's got an operable pancreatic tumor for a Whipple's procedure. She is in poor health and complains of breathlessness on exertion. The anesthetist asks the nephrologist for help in perioperative management. Now, here the reason for the referral is completely different. It's not that the anesthetist doesn't know what to do. It's not the anesthetist doesn't have time to manage the patient. It's that the anesthetist is asking the nephrologist to get absolutely involved in the management. And if I would refer to the nephrologist, what I would normally expect him to say is, look, the patient is breathless. She's most likely volume overloaded. Let me put in a permacath preoperatively. Let me do a session of dialysis before you take the patient to surgery. It's going to make your life a lot easier because the patient is not going to desaturate intraoperatively. And then talk to the anesthetist and say, look, I'll take over the management from you after the surgery, and I report the intensivist in the ICU. You tell me what your fluid management targets are, what hemoglobin you're targeting, so that I know what to expect once the patient comes back from surgery, and be prepared for post-op CRRT, right? So here, this reason for consultation is not that you're talking about a very technical issue. It's not like you're talking about stabilization. Here, you're actually getting involved in the management of this. Finally, let's look at case number 4, 65-year-old patient with Parkinson's disease, presence of the fracture of femur following a fall, presence for surgery. She's on carbidopa, levodopa, benztropine, and salicylic, and has just undergone electrode placement for deep brain stimulation. The anesthetist requests your guidance on the implications of the drugs in the disease. Now, this is the sort of case which you don't see very often because deep brain stimulation hasn't come into the country very much. We are really, there's so many medications that you require the physician to act like a sort of clinical pharmacologist and go over the implications of each drug with you. So what I would do if I was the physician to whom this was being referred to was to stress the necessity of not interrupting levodopa perioperatively to avoid the risk of post-operative rigidity. To stress that salicylic has effects on monoamine oxidase, and therefore you should avoid pethidine, because otherwise the metabolite of pethidine, norpethidine, could cause convulsions in the post-op period. To emphasize that the DBS needs to be switched off before surgery if cautery is being used, and therefore call the technician into the OT to switch off the DBS before surgery. And then go over things which the anesthetist most likely already knows about but may require to be emphasized. Emphasize the importance of decreased airway reflexes, emphasize the importance of excessive salivation, and also emphasize the importance of postural hypotension. Now, the first two have implications for the conduct of GA. The third has the implications for the conduct of spinal anesthesia. All of them can cause severe post-operative morbidities. You don't need to tell the anesthetist what type of anesthesia to do. Just make sure he has got a background knowledge of what the implications of the disease are. Because if he knows all these things, he can make a more rational choice of how to conduct the anesthesia. So in conclusion, when you get a referral, be sure exactly what is being asked for. Call up your colleague if you aren't sure what is needed, and have a low threshold for calling group meetings with all the specialists and the patients in the same room so that everybody knows what's going on and you're not just writing notes back and forth without actually understanding each other. Thanks for your attention.
I think, unfortunately, Dr. Bijan Bhattacharya could not join, so we should carry on with the discussion. May I ask, thank you very much. It was me who actually requested Professor Setlu to start talk, and he agreed with a very short notice, and thank you very much for giving us the talk, which is excellent. But I think it's a vast subject as to what to expect from a physician or a surgeon, because we all know it's a teamwork, and anesthetist is a part of the team in whether it's a major operation is a minor operation or even a procedure. As far as we are concerned, we, the gastroenterologists, we need anesthetist for a short anesthesia, as you know, perhaps in a procedure under, as you know, I am very poor in the knowledge of anesthesia, but our anesthetist allows us to perform the procedure with some propofol, short anesthesia, or ketamine, or whatever. So that is probably relatively minor. In this context, when an anesthetist is asked to give anesthesia for short anesthesia, what would you like to know? Perhaps you will find most of these patients will have some comorbidity and basic tests are already done. In that context, what are the minimum things that you want to know where a patient needs a surgery, sorry, minor operation or even a procedure done, short anesthesia?
Let's talk about LFTs in this context. When you're asking for a consult, one thing you should consider is the patient going to get better after surgery or worse? So in ERCP, there's a fairly decent chance that the patient's condition is going to improve because of the surgery. So even if the patient comes to you with a serum bilirubin of 17 to 19, you're not going to care too much. You're going to take up the patient anyway because the surgery is the therapy. On the other hand, if you're taking up a patient with, say, let's say alcoholic hepatitis, and the patient's got a serum bilirubin of 2 or 3, and the patient is being taken up for an elective surgery, you might tell him there's no way you're going to get operated until your LFTs come down to normal and you've been abstinent for at least 6 weeks. So the context really matters.
So in our short procedures, which about, say, endoscopy, colonoscopy, therapeutic intervention, or ERCP, as you mentioned, it doesn't take, it's a short procedure, and there you can afford to give some allowance depending on the situation. Is that what you told me?
Absolutely.
Okay, depending on the necessity. Even a routine procedure nowadays, a lot of people prefers having a colonoscopy under a short GA.
Right. No, I've undergone a colonoscopy myself, and after when they were trying to make the bend, I said I can't take it anymore. So even I required some anesthesia.
Okay, right. Any other questions? Because I'm just acting on behalf of Dr. Bhattacharya. Unfortunately, he could not join because he was there for a long time, but now he is not there. Any other questions to Dr. Setlu?
I think it's basically just us in the house. So.
Okay, anyway. There are other, I've given some examples, but you may find some other examples to give us some clue if you like.
Yeah. Oh, I think we can just pack up for the day. I think you're pretty much done over here.
Anything else?
Thanks so much.
Thank you very much.
Thank you, Dr. Setlu. It was a great talk from you.
Thank you. Thank you. Excellent talk.
Nice. And again, we have, we do not have Dr. Ranajit for this vote of thanks because of some personal reasons. So yeah, I'll request Dr. Monojit Mukhopadhyay to give a vote of thanks.
So good evening once again. Just a couple of minutes I'll take from you. First, I would like to thank all the speakers and the chairpersons, and particularly the audience for making this session very interactive. And as you've noticed that right from the very beginning, from September, when we started a monthly webinar, we've scaled new heights, and the level of the talks are of extreme high quality, and that has been maintained right throughout each webinar starting from September last year. So let's start with with Dr. The Master of Ceremony, Dr. Sujoy Mujumdar, who's done an excellent job in managing and this session. Professor D.G. Jain's opening remarks were as illuminating as is always. Dr. Subhachachi Ray welcomed everyone in his usual authoritative way. Now, coming to the talks, as you might have noticed, that we've had a mixture of a blend of youth and experience. And I would the first talk on comprehensive prevention and screening recommendations. As I must admit that I particularly, personally, and some of the others were apprehensive when we got this topic from him. But when we asked him to share the slide, we thought it would be a very interesting subject. And he's done full justice to the subject and his talk was aptly managed by Professor Shujoy Roy Chaudhary. Coming to the next talk on PCOS, we purposely chose two obstetrician and gynecologists to be the speaker and the chairperson. And as we mentioned earlier, it is PCOS managed, totally differently by the endocrinologists and the obstetrician and gynecologists. And we've done apt justice to the subject, clearing most of the doubts, and that's why we had quite a bit of an interactive session. And finally, I had the privilege to take Professor Setlu's MRCP clinical exam in Kolkata, and I'm very proud that he's actually, scaled new heights, and he's now heading the Department of Anesthesiology in AFMC Pune, and he's actually not only doing his normal work, he's setting guidelines. So I think we are very proud of what he's done. Unfortunately, Dr. Bijan Bhattacharya, who was a very, very senior member, couldn't join, but we missed his expert comments. And so we missed Dr. Ranajit Chatterjee, who could not join because of some bereavement of one of his colleagues. So with this, I would hand it over to Dr. Subhachacharya or Dr. Shujoy Majumdar to wind the session up. Thank you.
Thank you, Dr. Mukhopadhyay. Sorry, yeah, Dr. Rai, if you want to go ahead.
Okay. I think it was an excellent session. And I think before we end, I would like to request some of these organizers to stay for a few minutes so that we can have a little discussion, and others, goodbye to others, good night to everybody else. Dr. Shujoy Majumdar, Dr. Monojit Mukhopadhyay, Professor Dinesh Jain, and please stay back, and also some of the juniors like Dr. Gopal Chattopadhyay and Shayok Rai, please can you stay back so that we can have some planning for the next session?
Karvani can stay back as well.
Okay. Devashik, are you still around? Devashik? I think we could have a
Hello. Devashik is the backbone of our Royal College Indian chapter, as the logistic technical support for us.
I'll suggest let us not carry this discussion as there are many other people here in this. This is basically something which is supposed to be a discussion.
Others, please. We have done that in the past. Should we do that today, if possible? Otherwise, we'll have to meet again.
We request the non-members and non-fellows of the RCPI to